Demonstrating a procedure of phacoemulsification in intumescent cataract with double capsulorhexis technique where actually rhexis ran away. After doing routine steps of staining the anterior capsule with blue rex, we are doing the routine procedures. Now with the help of a 26 gauge needle, one nick has been put into the anterior capsule. You can see the fluid is coming out, and even creating a tiny rhexis is tough. Repeated injection of viscoelastic has been put. There is high intralenticular pressure which is making it tough for creating even a tiny rhexis. We ultimately succeeded, and now we are decreasing the intralenticular pressure by aspirating the lenticular material. Now nick is being put in this tiny rhexis with the help of the micro seizure. A larger rhexis is going to be created now with the help of the micro forceps. We are applying a tangential shearing force by grabbing the anterior capsular flap. What we are doing is that after every 2-3 hours, clock hours, we are releasing the capsular flap and again grabbing the base of the capsular flap. We have to inject viscoelastic as well. A round, regular capsulorhexis, larger in size, is being created. Both main port and side port is being used. Now at the end, you can see that while applying that shearing pressure, the rhexis actually extended into the periphery, though its margin is still visible. We are trying again, but it has extended to the periphery. So we started afresh by putting a nick in this capsular flap over here, and a fresh rhexis was created. We are doing hydrodissection very gently. One pole of the nucleus has been prolapsed. This is the supracapsular technique basically, because we didn't want to apply more force in the bag. It could have a devastating effect if it would have led to the extension of rhexis posteriorly, leading to rent, nucleus drop, vitreous prolapse. So in the supracapsular zone with the direct chop technique, the phacoemulsification procedure is being done. Low pressure, low vacuum and low power is being used. The whole press technique, rather procedure, is being done very slowly. Dispersive viscoelastic has been put so as to coat the endothelium, so that this emulsification doesn't lead to damage to endothelium. The procedure is being done very gently so as to avoid any chamber fluctuation. While putting the IOL in the bag, again this is a very slow injection, because any sudden jerk can lead to extension of breached rhexis. You can see that IOL is getting flipped, so we are just putting it back into its original position with the help of the viscoelastic, and now the IOL has been placed in the bag. While doing IA, we have to be careful not to engage the breached capsular edge into the port of aspiration. Over here you can see that IOL haptic is coming up in the anterior chamber, so it's being pushed back with the help of the viscoelastic, and a gentle manipulation of haptic is being done so that it is properly placed in the bag away from the breast plexus area.